Welcome to Airway Answers, expanding your breadth of knowledge. My name is Nicole Goldfarb, and I'm a speech-language pathologist and certified orofacial myologist. And I'm here to help you find your airway answers. We're in this together. Let's do this. Hello, everybody, and welcome. I am here with the wonderful Dave Evans, who is a top-notch physical therapist and also has advanced training in orofacial myofunctional therapy. You're one of the rare few, Dr. Dave, Dr. Dave Evans, that has these amazing skills. So he's actually the director, the head of our PT myofunctional therapy program at our office here in San Diego. I've worked with Dr. Dave for years and years, and he is amazing. And he did a presentation for our staff on TMJ disorder and physical therapy considerations. And I told him, I'm like, well, you gotta share this information to other people. It's just so amazing and so important. And we'll talk a little bit about Dr. Dave's journey as well, because it's been interesting how he has shifted from doing traditional physical therapy, whole body work, to also having an advanced focus on breathing, airway, TMJ, face, and all the myo stuff. Because if you know me, you kind of have to be obsessed with airway. So I've kind of sucked Dr. Dave into this rabbit hole, and it's fun, right, Dave?
It is.
So, okay, thank you so much for being here, because I know you're always so busy treating patients and directing the clinic that you work at. So I'm going to do a bio, and then we'll get into the presentation about TMJ and TMD issues, and then we'll talk a little bit more. So Dr. David Evans is a physical therapist, a doctor of physical therapy, a myofunctional therapist. He's a director of Coronado Office of Water and Sports Physical Therapy, and he has a lot of titles and training. I'm going to do a few of them. I'm going to read a few of them because there's so many. He's a board certified orthopedic specialist, a Titleist Performance Institute certified medical professional, certified fitness professional, certified in myofascial manipulation, certified in extremity evaluation and manipulation, extremity integration, spinal evaluation and manipulation, advanced evaluation and manipulation of the pelvis, lumbar, thoracic, spine, craniofacial, cervical, upper thoracic spine, and functional analysis and management of the lumbo-pelvic hip complex. He could tell us a little bit more about all those things. He is certified in he's also a TMJ or TMD specialist with the patients we work with, and has a lot of advanced training in PRI. So I think a lot of our listeners are familiar with PRI, Postural Restoration Institute trainings, and we can talk a little bit about that as well. So I'm going to read your bio, because those were just your trainings and some of your trainings and titles. So Dr. David Evans is a doctor of physical therapy who has a strong background in orthopedic and manual physical therapy. He's taken multiple advanced classes in the evaluation of all those things I just talked about, and has taken many continuing educations in the Titleist Performance Institute. So golf, right? That's 1 year things, Dr. Evans. And he has also received advanced training in evaluating and treating the TMJ in conjunction with the mechanics of the cervical spine. Dr. Evans developed some interest in orofacial myofunctional disorders as related to oral rest posture, mouth breathing, dental malocclusion, orofacial growth and deficient growth, airway dysfunction, sleep disordered breathing, and the relationship to myofunctional disorders in the cervical spine, posture, body pain, fibromyalgia, migraines, tinnitus, TMJ issues, and overall health in both children and adults. When treating many physical therapy patients, Dr. Evans noticed a component of their treatment might be missing if there's a myofunctional disorder that's not identified or addressed. And he truly understands the interrelationship of form and function of the orofacial system and the entire whole body musculoskeletal system. Dr. Evans embraces the idea that addressing the orofacial system and treating orofacial myofunctional disorders is an important overall well-being component to treating the entire body. Let's see what else I have about Dr. Evans. Oh, yeah. Dr. Evans believes that a good physical therapist needs to have advanced knowledge of anatomy and biomechanics to truly understand the complexities of the human body. With this knowledge, a physical therapist will have the ability to successfully evaluate and treat patients with a multitude of dysfunctions. Lastly, he believes that a physical therapist should not just treat the pain that the patient is experiencing, but should focus on treating the dysfunctional cause of the pain. And that is why we love our good PTs who get to the root cause of the issues, right? Because we know
Mhm.
body symptoms and what people are presenting with sometimes are just a symptom or a characteristic of some underlying dysfunction that needs to be addressed. And one other thing I love about Dr. Dave's treatment and most of the PTs at the office where you work is you do a lot of hands-on manual therapy. It's not like exercise based, go over there, do that, do 20 of those, and we'll talk later. They are hands-on with the patients. So thank you so much for being here, Dr. Dave.
Yeah, thank you for having me, Nicole. It's great to be on.
Now, I know we're going to get into your presentation, but I just want to ask maybe like how you got interested in the TMJ, TMD aspect of
Mhm.
patient care and how that like knowing myofunctional disorders and myofunctional therapy helped maybe change how you saw patients.
Yeah, absolutely. So, I have had TMD, TMJ issues myself in the past, and I found that as I was going through my schooling and my DPT program, there was options of being able to take courses in the TMJ and get a little bit into that realm. And so I took that and realized, you know what, I think I have a little bit more of an interest in this. And then, started treating in the clinic and, you know, honing my physical therapy skills as a whole and treating a little bit more like a regular physical therapist that you would, normally visualize in an outpatient physical therapy setting. And kind of the TMJ, TMD stuff kind of went not totally by the wayside, but I just wasn't treating in it as much until I started really taking some continuing education courses. You mentioned Postural Restoration Institute. I've also had courses from SFMA, Selective Functional Movement Assessment, DNS, Dynamic Neuromuscular Stabilization, other myofunctional therapy courses and education. And that's really where, through my continuing education, I started noticing there really is a pattern to this, and there's more to it. And so today, I want to talk a little bit more about how, from a maybe a traditional physical therapy side of things, we kind of look at TMD and kind of some things that we're looking for. But in actuality, there's so much to it that I realized, you know what, I need to go ahead and start treating more of not just the body and the head and the neck, but also the mouth and the airway as well. And being a physical therapist, I'm very fortunate to be able to, touch people every day, both literally and figuratively. But the idea that I'm able to work on all these joints, these soft tissues, and do exercise and patient education, it's kind of that blend of being able to help out the patient as a whole.
Yeah, and I think we give Dr. Dave some of the most challenging patients we see, which oftentimes are the TMD patients suffering from underlying airway issues in most cases, living a life with pain, facial pain, but also oftentimes whole body pain, headaches, postural and breathing dysfunction. And also sometimes those are the patients who they're not sleeping well. So there's also high sympathetic tone. So they're having a lot of
Mhm.
anxiety, depression, and those you've termed it like biopsychosocial components. Could you touch on
Yes.
what the biopsychosocial aspect is and how you address that?
Yeah. So what's nice in the realm of medicine is we're starting to understand, okay, there's not just like a physical side of things, so not just signs and symptoms. We're still in a medical society where there's still lots of specialization, but I think we're getting better at understanding the patient as a whole and understanding that there are biological, also psychological and social factors that might affect the patient as a whole. And especially when you're talking about, the sympathetic nervous system and fight or flight and constant stresses that we deal with every day, how that might have not only just a psychological and social impact, but how that might have a biological impact as well. So not only just the idea of, okay, we're treating the signs, we're treating the symptoms, we're just treating what's happening at this particular joint. We're really treating the patient as a whole because we want to get everybody back to a better life, and that might include more than just, oh, I have some, jaw pain or some knee pain or something like that.
Yeah, and as it's very evident, Dr. Dave, is you're very calming, like in your demeanor, the way you present, and it's a really good match for the TMD patients who might have that anxiety or a little bit more high strung to
Mhm.
have that calming effect. You can talk with them, you help calm them, and help get them out of pain. And we're going to talk about this, you'll go over in your presentation. But what I've learned is that a lot of the TMJ and the facial pain and the TMJ or TMD, but TMJ issues are very muscular based. And you, as a
Mhm.
PT and a manual therapist, have the power. You have the power in your hands to help relieve that pain. I'm wondering though, before you learned about Airway, do you feel like there were things you missed in some of your other PT patients that maybe looking back, because we've all had that. I've had that with my speech
Yeah.
therapy patients where you're like, oh
Mhm.
man, that person, like you could clearly remember certain people and faces, and also let me know about that. But also, people you see now, are you more aware of this whole craniofacial aspect and airway?
Yeah. Yeah, absolutely. And I think we'd all be kidding ourselves if we didn't say that we've treated perfectly. I know certainly, early in any career, you make mistakes. And the nice part is recognizing maybe things that you might have missed and how you can improve upon that. So I can always think of a handful of patients that I'm like, oh man, I'm missing something. I know I'm missing something. I just don't know what it is. And as a profession and as a medical professional, we should always be trying to then look for those answers. And I've found those answers now a lot in my patients with oral facial myofunctional therapy and kind of entering into this world a little bit more. And what's nice is even if I have patients that are not coming to me for specific TMD issues, or if they have not been, referred from a dentist or a speech language pathologist colleague, even if I'm just seeing a normal patient that's having, lower back pain, seeing how breathing, the diaphragm, the rib cage, tongue positioning, how that can affect a patient. Because one thing that's kind of unique about how we can view the human body is that we don't really we shouldn't be viewing muscles as just one individual muscle. We should be viewing everything as chains. We call myofascial chains, and so how these things are connected and how the base of the tongue has fascial connections down into the deep neck flexors and the hyoids, down all the way into the diaphragm, the abdominals, and the pelvic floor, and all the way down to the feet. And so seeing how tongue positioning, posture changes, breathing, sleep disorder breathing issues can lead to more pain just in normal patients that I see in the physical therapy clinic. So that's nice about getting into this world is that it's kind of broadened my view on not only past patients but also present and future patients.
Yeah. And then the team of people you work with, like we work together, our speech myofunctional therapist, you as a PT, but what other specialists do you feel like now you work with that you maybe didn't in the past? You mentioned dentists.
Mhm.
That's,
Yeah, certainly dentists, orthodontists, sleep medicine doctors, neurologists, and there's even been some of my patients that have seen, chiropractors or acupuncturists or physiatrists that have a little bit more of this, education and background. Um, and that's really what I've found is that as much as we all want to be the one person that can fix our patient, it really does take a team approach. And so having a myofunctional therapy side of things, a dental side of things, a medical side of things, kind of really leaning into some of those medical professionals to be able to help you help the patient out.
And we had a staff meeting of all the clinic directors for water and sports PT a while ago,
Mhm,
and everyone was going around and they were asked, "What is your favorite thing to treat or your favorite aspect of the job?" And when it came to
mhm,
you said the TMD patients, the TMJ patients. I was like, "Oh my gosh!" I was so happy. I got like chills. I was want to cry. I was so happy because
mhm,
it's so neat to have you like you've been doing this for years and years and years as a physical therapist, and for the last few years, having this sort of advanced training in the myofunctional realm and a different aspect of the TMJ component, and to have that shift to be one of your favorite patient populations. And we have patients
mhm.
seeking you. I got an email recently. I found Dr. Dave online. Is he still working? I need help with my TMJ issues. Like it's just really great to see you loving that aspect of it. A lot of people find that to be a challenging population.
Yeah, and I think unfortunately, it's viewed as challenging patients because a lot of times uh, we're not exactly sure sometimes what that patient needs because they are that biopsychosocial patient. We might find that, okay, I can provide one thing, but I know I can't provide it all. And that's where that team comes into play. But, a lot of times, I hate to say it, sometimes what can happen in modern medicine is these patients go see maybe their physician or so that maybe doesn't have as much training or education in this, and they're kind of passed off to the next person and passed off to the next person, passed off to the next person, and sometimes it's a real shame to see some of these patients just by the time they get to you, and kudos to everybody that's listening and watching to this because. Uh, you are a part of the solution to help this is that sometimes by the time these patients get to me they might have seen multiple therapists, both physical and mental. They might have seen many dentists, they might have seen many physicians, and they're kind of almost just so discouraged, and then they hear about myofunctional therapy, and that kind of gives them a little bit of a jolt of energy, a little bit of hope. And it's nice to be able to then kind of stoke those flames of hope and really be able to kind of really, really change these people's lives when maybe their whole entire life they've kind of been told, well, I don't really think there's much we can do for you, or oh, well, you have problems, but they're not that bad. You should consider yourself lucky. So,
So that is so true. The I think when we say like, oh, these might be more difficult patients, it's because they are burnt out and discouraged in many cases because they've been misdiagnosed and they're be putting on like antidepressants or anxiety medication or other things, or being told maybe they're crazy, or oh, you're just experiencing pain, or you're sensitive, or whatever the other symptoms are, but not getting to that root cause. And those TMD patients have a lot of them have sleep dysfunction, sleep issues due to poor jaw growth. So before we get into your presentation, last question I want to ask is, it sounds like there is study on the TMJ in physical therapy programs. Is there any addressing of airway? Is that talked about in doctoral programs? Any of this stuff?
I think in the physical therapy world getting better at understanding breathing, the diaphragm, the rib cage, how that can have an impact on patients as a whole. And so I think we are getting better at it. I think as more and more research comes out, and some of these real, top physicians and top physical therapists are kind of moving more into this realm, and more of this information is getting out there. I think we're starting to see more literature come out, and physical therapy schools, DPT programs talking about things more, which is encouraging and which is good. Um, there's still a little bit of a lag in terms of this kind of specific myofunctional therapy education, but I think as a whole, the profession and DPT programs are moving in a direction that I'm very happy with in terms of understanding the patient as a whole, as well as how breath work and sleep issues can affect patients as a whole.
Sounds like it's progressing, but like most of our
Hmm.
fields, it's not even in most medical field MD programs, there's not much talking about sleep and sleep disorders. There's
Hmm.
like a few hours, maybe 4 hours in a whole medical program. So hopefully that will bump up as people start to realize its impact on overall health. I know Brad
Yeah.
Gilden, who's one of the PTs and the head of the PT Airway program for the AAPMD, is trying to have an added airway course of study or an airway specialty in the physical therapy domain. And I think a lot of people are signing, contracts or whatever, signing things for that to try to get that approved. So that would be
Hmm.
amazing because there's different specialty areas, and that would be great. And I know I said the last question, but one more quick thing, and then we're going to get into your presentation. SFMA, PRI,
Yeah.
DNS. Can you just quickly summarize what those are?
Yeah, so anybody that has any experience in SFMA, PRI, DNS knows that it can be a lot of information. It can be a lot of stuff, but to kind of tidy it up and kind of wrap it into a little bit of a bow, these are different treatment philosophies and techniques that I've kind of had training in to really view the body as a whole and to look at how breathing, how neurology, and how the musculoskeletal system can really affect the patient as a whole. And you look at maybe some of these courses, you look at some of these theorems, and a lot of it is based off of compensation patterns and poor movements and activation of wrong muscles because we're just not breathing or holding our posture, if you will. Posture can be different things to different medical professionals, but some of these theories are all wrapping together how respiration, neurology, and musculoskeletal system can really help the patient as a whole. And a lot of it boils down to what we call motor control and how the body and brain activates those muscles. And I think we can see in the from physical therapy side of things, myofunctional therapy world, a lot of it can be about compensations and utilizing the wrong musculature, and looking at these myofascial chains of how maybe one part of the body is affecting other parts of the body, and how we can go ahead and utilize our respiration to go ahead and correct that. And that's what's nice about these different programs is that they're all different theories and different treatment protocols and different ways of evaluating the body and treating the body, but they're all at their root cause. It's all about respiration. It's all about neurology, and it's all about the musculoskeletal system.
And
So that's
SFMA
why
is
it can all be super helpful.
and SFMA is selective functional movement analysis. Is
Yep.
that correct? And PR is
Selective functional movement assessment.
assessment. Okay.
PRI is Postural Restoration Institute, and DNS is dynamic neuromuscular stabilization.
Okay, awesome. Really great
Mhm.
stuff. So let's
Yeah,
queue up your presentation here and
absolutely.
should be right there on the screen. So go ahead and get
Yeah,
started on teaching us about this.
fantastic. Yeah, so this is going to be basically TMD from a little bit of a physical therapy side of things. If you're a physical therapist and you're listening or watching this right now, some of this might be review for you, but hopefully we can go ahead and educate some of our listeners and viewers to at least see how, from a physical therapy side of things, this is kind of taught and how some of this stuff is kind of looked at. So uh, first, I think we all should really make sure that we understand the TMJ anatomy and how basically this is affected. And there's a lot to it. This isn't everything, but this is kind of everything in a nice, tidy package here. So when we're talking about the TMJ anatomy, we need to actually look at the TMJ joint and the mandibular condyle, which is going to be fitting into the mandibular fossa. So we have the jaw, we have the fossa fits into it, and then we have the disc on the left-hand side of the screen here. That's the blue there. And what is kind of interesting about this disc and the TMJ is that it's a biconcave shape. So the interesting part is concave is kind of like the inner part of a C, if you will. And the the way that essentially the TMJ works is that it allows a rounded bone to fit into more of a socket, and then allows a little bit more freedom of motion and anatomy and stability, to better fit. And the superior stratum, those are fibers that attach the disc to the mandibular fossa, and the inferior stratum are fibers that attach the disc to the mandibular condyle. Now, what's really important, are the muscles of the TMJ. And Nicole, as you alluded earlier, the muscles can have such a huge impact on TMD. And when we're talking about muscles, the important part to understand is not only is this just at the actual local, muscle level, but this is also neurology as well. It's called the neuromuscular system as a whole. So the brain is telling the spinal cord, which is telling these nerves, which is telling the muscles to contract and work. And so, we can have muscles that are supposed to work, that they're the way they're supposed to, but sometimes any imbalance in that system can really cause muscles to not really work correctly. So, the two big powerful muscles of the TMJ are the temporalis and the masseter. So temporalis fits right there on the temporal fossa, right on the outside there of the skull. And then we have the masseter muscle, which is on the side of the jaw there. Now, both are responsible for mandibular elevation. They are our muscles of mastication. They help chew and break up food. Now, what the temporalis and masseter also do is that when you're closing, they will protrude or bring back the jaw as well. So not only will they elevate, but they'll also protrude. And a lot of times, unfortunately, these muscles, if they are working way too much or are way too strong, and maybe we're not using our tongue muscles as much, or we're not using what we call our lateral and medial pterygoid, which we'll get into in a second, if we're not using those muscles correctly, then a lot of times these muscles will be what we call hyperactive or hypertonic, in that they are working much harder than they should, and that can bring on bruxism. And we can have bruxism and clenching and grinding during awake hours. If someone has a lot more stress, this is the biopsychosocial side of things. The human body was not really made to have micro stresses all day, every day, but that's kind of the society we're in right now. You wake up, you're rushing to. I have a 7-month-old at home, so rushing to get him ready, get him fed, get him off to the grandparents' house, and then I'm sitting in traffic, getting to the clinic, and then I get there just in time to get ready for my patients, and then I have the stress of patient care, and then I drive home and I'm dealing with traffic there. And then by the time that I'm able to finally calm down, I've gone through hours and hours of stress. And so a lot of times that can cause the clenching and the grinding, which elevates the mandible and gets the temporalis and masseter muscles to be working much more than they should. And then really a lot of the most important part of bruxism is the sleeping. And having bruxism during the sleeping hours, due to poor airway opening and poor tongue positioning, poor tongue rest posture. And so unfortunately what can happen there is when we have bruxism during the sleeping hours, a lot of it is to go ahead and actually activate the musculature to open up the airway more, so we can breathe better. But the temporalis and masseter muscles are really the main culprits in a lot of TMD and TMJ pain from a physical therapy side of things. Now, I had also mentioned two muscles here, the lateral pterygoid and also the medial pterygoid. Um, these muscles are much more deep than the temporalis and masseter muscles, which are considered your more superficial muscles. So the lateral pterygoid, that is really important because it attaches to the disc, it stabilizes the disc on that mandibular condyle as we're opening and as we're closing. So what's really important is the lateral pterygoid and the medial pterygoid helps us with opening and protrusion. It also helps the medial pterygoid a little bit with elevating the mandible. But the lateral pterygoid can be really important for lateralization of the jaw and opening and stabilization of that disc. Now, you also have your suprahyoid muscles, your muscles above the hyoid bone, your Adam's apples considered. You have your digastric, geniohyoid, stylohyoid, mylohyoid. You also have your infrahyoid muscles, which are below that hyoid bone. So your sternohyoid, sternothyroid, thyrohyoid, edomohyoid, lots of hyoids there. But those muscles are really important as well because those are going to be helping with the swallowing process. And those muscles actually have fascial attachments in through the tongue and the base of the tongue. So those can also have an impact on the TMJ as well. And unfortunately, what can happen sometimes is when we have considered poor posture, maybe our shoulders are rounded while we're working at the desk for so much, or our head is protruded forward. What can actually happen is you have a length tension relationship that with these muscles that is not optimal. These muscles actually get stretched out, and the little nerves within those muscles that we call the muscle spindles, those are like, hey, we don't really like to be stretched. So they'll contract and they'll actually help push that mandible back up into the mandibular fossa. And, light compression forces over time, hypertonicity of these muscles, all of that, can lead to pain and degeneration over time. Now, with the TMJ arthrokinematics are just basically what the biomechanics are, how the joint works. Now, 40 to 50 millimeters is considered normal opening. That can be different for females versus males. You might have some patients that are maybe have hypermobility syndromes, like an Ehlers-Danlos patient, that might have a little bit more because their connective tissue is not as, it's more pliable. It's much more stretchy than it should be. So sometimes their opening can be a little bit more. Now, essentially, when we're opening our mouth, the first 12 millimeters are actually a rotation of the mandibular condyle. The mandibular condyle actually hasn't moved on the fossa yet in the forward opening. It's just rotating. And then the final 28 to 38 millimeters of opening are an actual anterior translation. So mandibular condyle is actively moving forward. And there's what we call a 4 by 1 by 1 rule. And typically, for 1 millimeter of lateral excursion going to the side and 1 millimeter of protrusion going forward, you usually get that for every 4 millimeters of opening. So typically, let's say if somebody has 40 millimeters of mandibular opening or TMJ opening, then we would consider 10 millimeters of lateral deviation to be normal range of motion. Now, how do we measure the range of motion? We can use therabites, and you can essentially hook it onto the teeth there and have the patient open as wide as they feel comfortable. I generally have the patient open as wide as they feel comfortable and not as wide as they can. Sometimes, like I said, with these hypermobility patients, if you have them open as wide as they can, it's oftentimes much farther than they should. and we want to protect the disc and the condyle. So we open as wide as we can, and then we can go or as wide as we feel comfortable. And then we can go ahead and check how many millimeters of opening that we have there. And then when we have the measurement of lateral excursion or lateral translation, we can go ahead and have the tooth in the middle. We can hold the therabite up, have them do some lateral translation, right, left, and we can go ahead and see how many millimeters they have of that. And then that really can help us determine if they're lacking in mobility of one side versus the other. Oftentimes, you might get somebody, just to make the math easy, have 40 millimeters of mouth opening, but then maybe they have 10 millimeters of left lateral excursion, but maybe only 5 millimeters of right lateral excursion. And that might, help us in the evaluation try to determine, okay, well, there's clearly something there. So is it muscle? Is it joint? And that's where we can go ahead and try to figure out from there. Now, one thing that for the TMJ that can cause a lot of TMD issues is what we call anterior disc displacement. And in a DPT program or going through physical therapy, this is kind of considered one of the most common types of TMJ pain. If anybody has ever, opened their mouth and had clicking or popping in their jaw, this is typically what's happening. So with an anterior displacement, in phase one, you're going to have the initial displacement with the condyle moving forward. The reduction usually happens in the first 10 millimeters of opening. And, phase one, there's usually no pain or anything like that. There's no popping or clicking. It's just the disc is sitting a little bit more forward on that condyle than it should. Now, phase two is when we might start having, hearing sounds. And typically what this means is that phase two, we will have reduced, the disc will come back onto the condyle between 10 to 20 millimeters of opening, and we get that initial click, that initial kind of like pop that sometimes we hear, or maybe sometimes other people might hear. Maybe you're having a big yawn and you hear a pop, and your significant other on the other side of the couch is like, what the heck was that? That's kind of what's starting to happen. Now, we associate a lot of that with nail biting, with clenching, with a lot of these parafunctional habits, unfortunately. Now, phase three, you can have that disc moving even more forward, and that reduces or comes back at 20 to 30 millimeters of opening. And you can even have a double click. So you can have that initial click of the disc coming back onto the condyle as they're opening their mouth, but then you might have a secondary click when you or pop when you close your mouth, and that's the disc coming back off of the condyle, because remember, with this anterior disc displacement, the disc is no longer sitting on that bony condyle. Now, what's nice about this is that the patient can still reduce the disc. So the patient can still get the disc back on and unfortunately off the condyle. Now, what happens with kind of phase three of anterior disc displacement is that the disc has come too far forward to the point where it's starting to compress what we call retrodiscal tissue. So tissue that's behind the disc, where there would be some gapping and openings, and there's nerves and blood vessels and all sorts of things in there, and that tissue can be compressed and kind of really start causing pain for the patient. And then the last and most significant anterior disc displacement is phase four, and this really, really affects patients. This is the disc is fully dislocated, and that disc is no longer even really, unfortunately, touching the condyle, and that can limit opening by 50% because the condyle can rotate. but it can't translate forward because the disc is in the way, unfortunately. And so these patients, if they're like, oh, well, my jaw locks, I can't open, a lot of times then we're experiencing this kind of final stage of anterior disc displacement. You can also get posterior disc displacement. It's kind of like an open lock. The disc has translated back behind the condyle. It's a little bit more rare. Usually you're going to get an anterior disc displacement with patients, but posterior can happen. And a lot of times it can be a prolonged mouth opening. Maybe somebody goes in for a dental procedure and maybe a little bit more work is needed to be done. And unfortunately, maybe they have to have their mouth open for a lot longer, and that can kind of displace the disc further back. Now with these, there's there's non-surgical interventions, similar to those used for anterior disc displacements. So usually the first option is you can get the disc back on, do some traction mobilization to get that disc back on. All right. Now, another thing that as physical therapists we'll look at as well is we'll look at what we call deviations here. And when somebody is opening the mouth here, we might see what's called a C deflection. And that is the jaw moving to the side of dysfunction. So a lot of times what can happen is as we're opening and we have a rotation, then translation. Maybe one side rotates and translates, but maybe the other side doesn't really translate or move forward with that mandibular condyle. So what happens is kind of a hanging back in that jaw then deflects to that same side that the issue is. Very, very common for it to be a muscular component where maybe the masseter, maybe the temporalis is pulling that jaw or laterally translating that jaw to that same side of tightness. Very common to have that. And then the other deviation we look at is what's called an S deviation. This is a motor control dysfunction. So when I say motor control, that is your nerves and your brain and your muscles understanding what muscle should be working and in what order and how they should work. So sometimes we might get it where the pterygoid muscles or other musculature of the jaw is not as stable because maybe there's not that proper neuromuscular stabilization or muscle contraction. And so it'll kind of shift side to side, kind of like an S. And sometimes you might even get this a little bit after you've treated the C deflection, where you've maybe loosened up the masseter and temporalis, and then now all of a sudden, as they're opening or closing, you might get a little bit of that S deviation because those muscles that were not really required to work as much now have to work because you've removed the compensation because the masseter and the temporalis isn't having to work as much now. All right, now I have a little video for Airway and TMJ here. I think we might have a little bit of time here. Hopefully the audio plays. Nicole, let me know if the audio is not playing.
I don't hear audio.
Okay. All right, so maybe a little bit of some technical difficulties. So I think maybe what I'll do is I'll just try to narrate this. So as
see if is the volume on your computer up, or it looks like it's muted on your screen.
Yeah, I muted it, so I'm not hearing it as much. Okay. Yeah, but what can happen is when the tongue is hanging down, now all of a sudden we have improper airflow. The adenoids can go ahead and tonsils can get bigger. Now the tongue is coming down and it can push out against the teeth, creating open bites. And when we don't have the tongue up providing some support and structure. Now these cheek muscles have to work a little bit harder, and we get narrowing of that palate because the tongue can't support that palate. All the dentists, orthodontists can go ahead and speak on that a little bit more. Now, proper swallowing, ideally the tongue should be able to come up, but if we have improper swallowing, then the tongue still push out, and that's also going to go ahead and continue to create open bites as well. So this is really important. We're talking about how the musculature should work appropriately, because if it's not working the way that it should, well, then now all of a sudden we have open bites, we have malocclusions, we have compression into the actual TMJ itself. There's that anterior disc displacement right there. That's that compression of retrodiscal tissue. Now all of a sudden that's ticked off. All of the masseter and temporalis muscles, we're having pain and inflammation, and that is affecting people's life and daily activities. Now we're also having other muscles kick on, other pain, headaches, things like that. And now all of a sudden, clenching, grinding occurs, all because that tongue is not sitting in the proper position. Tooth wear can happen as well because tongue is not sitting in the proper position while we swallow, or while we're breathing, or while we're sleeping. Perfect. So that right there is that stage 4 of anterior disc displacement. That shows that the condyle can rotate but can't translate forward. And when we have that tongue back in blocking the airway, now all of a sudden we are affecting how much air can get through, and someone might need to go into this forward head posture, bringing the mandible forward, opening up the airway, and then all of a sudden you're dealing with neck pain and discomfort. So now there are what we call, there's referred pain. And so a lot of this, think of referred pain. We have different organ referred pain patterns mapped out. Classic one is a heart attack. The issue is in the heart, but someone might be having excruciating pain in through their jaw, their upper back between their shoulder blades is a common one for females, as well as down the left arm. So someone might be having pain in their arm even though the issue is at the heart. Well, muscles are no different. So these are the Travell craniofacial referred patterns. And so we can see how the upper trapezius, the sternocleidomastoid, the suboccipital muscles, these can all refer pain into the head. Now, the reason why this is important is because it shows how people with TMD and these muscular imbalances and poor airway opening, they have to compensate by bringing that mandible forward, by bringing the head forward, and now all of a sudden you are tightening these muscles, you're shortening these muscles, and you're causing myofascial referred pain, and they can have headaches. Very often in the physical therapy realm and world, you'll get people with headaches and neck pain, and you can clear that up a lot of times by just doing a little bit of what we call active muscle pumping, a little bit of myofascial release. You can get into these trigger points here, and that can reduce that pain, that can reduce that headache. Now, for the TMJ muscles, the lateral pterygoid can refer by the zygomatic arch and into the cheek. The right smack dab in the TMJ as well. So if someone's pointing out their jaw and they're like, I have pain right at that joint, could be joint related, but could also be the lateral pterygoid as well. The masseter muscles, they can refer pain into the teeth, upper and lower teeth, into the ear. Someone has an ear kind of ache, or if someone is having issues swallowing, then they can't clear their ears and pressure can build up, but it can also be part of the masseters as well. The temporalis can refer pain into the upper teeth as well as the temporal bones, and kind of lead to these classic headaches. And a lot of times what you can do is you can take these trigger points and kind of just the classic, oh, headache of just kind of rubbing your temples. A lot of times the fact that that helps is because you're hitting one of those trigger points, which is referring pain. Now, with that forward head posture, we're going to have a loss of what we call the cervical lordosis. So the spine, the neck, should have a nice kind of backward C curve if we were looking from the side here. And unfortunately, if we don't have good posture, maybe the airway is an issue, and we have to bring the head forward and bring the mandible forward, then we have that loss of cervical lordosis and those bones become straightened. We then have what we call OA extension, which is the base of the skull that extends, that tightens up those muscles. Then we also have vertical positioning of the sternocleidomastoid and scalenes, and we have a vertical positioning of these muscles that causes more pain in through the neck, because of the way that these forces are putting pressure and stress straight through the cervical spine. And then we also have excessive pull on the hyoid musculature. Like I mentioned previously at the beginning of our presentation here, and a lot of times what can happen is when we have that excessive pull of the hyoid musculature, well, what that's going to do is that's going to take the mandible and that's going to go ahead and shove it back into the mandibular fossa. Now all of a sudden you can have anterior disc displacement. You can also have increased degeneration for that TMJ. One thing to consider as well is the occipital nerves. These can cause headaches as well if you have that forward head posture because of the poor airway opening that can compress the greater and lesser occipital nerves. These muscles can be entrapped in the suboccipital muscles, and a lot of times this can lead to a classic what we call ram's horn headache that starts at the base of our skull. Could be on one side, is very often on both sides, and it can wrap around the back of your skull to the top, all the way kind of to the front of the forehead. And a lot of times, if we have that forward head posture, it shortens those suboccipital muscles. And now all of a sudden, these nerves are being pinched and irritated, and it can go ahead and cause us those headaches. Now, kind of some treatment considerations. You can do some master and temporalis neuromyofascial release. A lot of times what can work very well is doing some cross-friction mobilization on a Travell trigger point. In the physical therapy world, we can go ahead and utilize soft tissue treatment techniques. And it's expected or kind of normal to feel some amount of pain or discomfort anytime you're trying to make change to something that is maybe stubborn or doesn't want to totally change. Then they might not want to go ahead and relax the way you want. And so when you're getting into these muscles, you might feel some pain, but we never really want to go beyond a 4, maybe 5 out of 10 on a pain scale. We always want to have some kind of normal tolerance. If somebody has a lot of hypersensitivity, a lot of times we can get that with the biopsychosocial side of things with these TMD patients. We really don't want to go beyond a 2 or maybe even 3 max, because if you go too hard with these muscles, then you can also go ahead and contribute to more inflammation and pain, and all of a sudden that patient is far worse than they would normally be. You can also do a lateral and medial pterygoid release. I would only have a medical professional do this on you. I wouldn't really do this yourself, because you need to go inside the mouth or as this woman's doing here, you need to go around the mandible, and there's a lot of sensitive structures there, nerves, blood vessels, and so I'd really only have a medical professional that was trained in that do that. Um, for physical therapy, we would also do some gapping mobilizations and lateral translation moves. It might be a technique where if we're not getting the opening because maybe that anterior disc is pushed forward a little bit, we might go ahead and do a translation mobilization or a gapping mobilization to physically take that mandibular condyle and pull it away from the temporal fossa and then actually get that disc back on there. Or sometimes we find that the tissue surrounding the joint, maybe post-surgery, maybe post jaw surgery, is too tight, and so we might want to loosen up some of that tissue. Really, only a physical therapist or someone that is trained in this that can legally put hands on a patient should really be doing these because they can be very tricky, and you don't want to necessarily over mobilize because that can cause other issues as well. Big one, orofacial myofunctional therapy. A lot of what I what I kind of showed in terms of the joint mobilizations and working on these trigger points, that's kind of the short-term solution. The orofacial myofunctional therapy with exercises, proper physiologic rest posture, drinking, eating, saliva swallowing, parafunctional habits, working on that nail biting. A lot of that is more of the long-term solution. Also having someone work on diaphragmatic breathing as well. There's tons of exercise videos out there on how to properly dynamically breathe. Working on the SCM, scalenes, and even the first rib can be helpful. Doing a suboccipital release, and then even cervical and thoracic manipulations can help. What we call high velocity, low amplitude mobilizations can really help because you can get a crack or a pop out of a joint, certainly in the neck or the upper back, which can then reset the nervous system and make it so that there's not as much neuromuscular tone or referred pain. And then lastly, postural re-education. Have them consider, well, your workplace might not be the best for you. Let's look at your chair. Let's look at how your workplace is set up. Let's talk you through giving you a little bit more support and setting a timer at your desk for every 30 minutes so that it beeps and you can do a posture check. Oh, let me get my shoulders back. Let me get my head over my shoulders. And all of those different things can really be good treatment considerations. And that's all we have there.
That was such a great presentation. I'm going to be watching that at least 3 more times to just absorb all those details.
It's a lot of information, so
it's
yes.
so great. And this is why everybody working with a patient who has facial pain, bruxism, TMJ issues, diagnosed TMD needs a good physical therapist on their team. In addition to that, one of your last slides, the one that said treatment considerations, and the first thing you wrote is the OMT, orofacial myofunctional therapy. So addressing function, that is so important because we can do the manual piece, but if we're not reorganizing, restructuring oral rest posture and functioning, all that other stuff might not hold. It might not maintain, like you said. So I thought that was so great and important you mentioned that. And also addressing the airway component for long-term success. And I just think that was such a phenomenal presentation. And I'm so excited to share this information with everybody to help people get a better understanding of our TMD patients. I just thank you so much for sharing your wealth of knowledge with everybody. We appreciate it so much. I know you have more meetings and patients to see today, so I don't want to take any more of your time, but thank you so much, Dr. Evans, for teaching us today.
Well, thank you, Nicole, for having me. Pleasure, and glad that I could go ahead and provide just more education on maybe how physical therapists fit into this realm. So
yes, and such an important piece. And if people have questions, they can reach out to me or reach out to Dr. Dave Evans from Water and Sports Physical Therapy. So you can go on the website, his information's there, and he can help guide you, your patients, direct any of your questions to him for help in this realm. Thank you so much, Dr. Dave. Have a great rest of
Well,
your day.
thank you, Nicole. You as well.
Thank you so much for joining this episode of Airway Answers. I'm hoping some of your airway questions were answered. Please feel free to give us a rating or a comment. And if you have any further questions, you're welcome to email me at nicole@airwayanswers.info or check out our site at www.airwayanswers.info. Thank you so much and join us for the next one.